This next patient is a 17-year-old male who was recently diagnosed on the 12th of December with a small blue cell tumor in the right lung, as well as bony metastases on his vertebrae. He was recently admitted to our facility on the HEMONC service on the 28th of December for worsening bone pain that was unable to be relieved by narcotic medication in the outpatient setting. His admission chest x-ray showed a large right pleural effusion, and so they subsequently placed a pigtail chest tube on the 31st of December. There was no infection noted at that time, so they went ahead and initiated his chemotherapy regimen. Prior to that, they obtained a pre-chemo echo, which showed a small pericardial effusion that was not seen on the previous echo on admission. This patient was hemodynamically stable. He did have some increasing hypertension, and so they started him on amlodipine, a clonidine patch, and some PRN hydralazine. His blood pressures became more in the normal range, but he did develop some sinus tachycardia. It sounds like in the last 48 hours, he became worse with his sinus tachycardia, and then yesterday morning complained of increasing chest pain. So they went ahead and ordered a CT of his chest, and cardiology was consulted, and the pericardial effusion was now in larger, moderately sized compared to the small effusion they noted on the echo. And so he went in yesterday for an emergent pericardiocentesis in the cath lab. While in the cath lab, they drained close to 600 mils of serosanguinous fluid. They placed a pericardial drain, and they brought him back to us in the PICU overnight for closer observation. Since then, he seems to be doing better. On my exam this morning, he verbalized that he was much more comfortable. His chest pain had improved. We did grab a BMP this morning that showed a decrease in his white blood cell count. Clinically, he's also breathing more comfortably. The pericardial drain continues to be in place and continues to drain. And so I will go by systems to present this patient. From a neuro standpoint, he has been appropriate this morning. He's alert, he's more comfortable, he verbalizes that his pain has improved. He continues on a morphine IV infusion as well as a Narcan infusion. We also have PRN boluses. It looks like he got 2 to 3 boluses overnight, which is an improvement from 5 to 7 the previous night. We will continue to assess his level of pain and adjust his medication accordingly. He follows directions well. He corresponds and communicates appropriately. I do not have any changes to make from a neurologic standpoint today. Respiratory, he is on 4 liters high flow nasal cannula. His FiO2 is set at 25%. That is much better than the face mask that he was on the day before with his increased work of breathing and chest pain. He seems to be more comfortable with oxygen saturations in the low to mid 90s compared to yesterday where they were in the mid to upper 80s. His work of breathing has also improved. He has much less retractions than he did yesterday, so we will continue to watch his level of work of breathing and decrease his oxygen support as tolerated. From a cardiac standpoint, he is warm and well perfused this morning. His pulses are 2s to 3s, both in the upper and lower extremities bilaterally. He has great cap refill, less than 3 seconds in all extremities peripherally. He does have sinus tachycardia, but his cardiac output seems to be appropriate, and he does have a pericardial drain still in place. We will continue to observe that for any sudden changes, stops, or increases in fluid. He also has his right pigtail chest tube that is stable and draining steadily and has also decreased in the last 24 hours. His heart tones oscillated. He had normal heart tones. I did not hear any murmurs or gallops or abnormal rhythms. or abnormal heart tones, I apologize. We will continue to watch his hypertension. His heart rate has ranged from 80s to 100s in the last 24 hours. His blood pressures have been 130s to 140s systolically, which is an improvement from 150s to 160s in the previous 24 hours. We will continue his amlodipine, his clonidine patch, and intermittent hydralazine for his blood pressure. From a GI FEN, his abdomen is soft, non-distended, very hypoactive bowel sounds. He does have a Foley catheter in place and has had 3 per kilo per hour of urine output in the last 24 hours. His INO balance is still positive, about a liter. We will continue to monitor that and his urine output, as well as his electrolytes, to ensure that he stays within a normal range. Overall, I feel like this patient is doing much better since his emergent pericardiocentesis. We will continue to monitor the drainage output as well as his respiratory support. We will leave the drain in place. We will repeat an echo in the morning per cardiology's recommendations. The big thing for this patient today, again, my impression, this is a 17-year-old male diagnosed with small blue cell tumor in the right lung who went in for emergent pericardiocentesis in the cath lab yesterday after chest pain and a moderate-sized pleural effusion was detected on a CT of chest. He was admitted to the PICU overnight. He is now hemodynamically more stable, clinically looks better. We will continue to observe his drainage output and transfer him out of the ICU within the next 24 hours as long as his respiratory support and cardiac hemodynamic stability remains appropriate. The big plan for him is to allow HEMONC to follow his course and chemo regimen more closely. The family is recently being briefed from the pathology report of the specifics of this tumor and what options they may have, and those will be discussed more closely. We will continue to provide comfort and supportive care here in the ICU until further changes are made to transfer him to the HEMONC service later today.